Good evening, dear madam and my dear colleagues. I welcome all of you to the Young Family Physicians Forum. First of all, I make this an opportunity to thank our madam, Dr. Alanta Senaratne, for guiding us not only in this event, but also in our journey as registrars. So today's presentation will be conducted by Dr. Udan Tissera. He was a graduate. He was graduated from Kottawal Defense University in 2019, and he is a first-year registrar in family medicine. Today he is going to talk on voice with a noise. I'm sure it will be a very interesting presentation. As usual, you can clarify your queries after the presentation. At the same time, you can post your questions in the chat box. So I kindly request you to stay until the end of the discussion. So without further ado, I'm handing over to Dr. Udan to continue with his presentation. Udan.
Thank you, Dr. Manoj, my dear colleague, for your kind introduction. Good evening, dear Madam Dr. Lalanta Senratha, and my dear seniors and my colleagues. Thank you. Thank you again for inviting, give this opportunity to talk in this Young Family Physicians Forum today. So let's move into our topic of discussion today, the voice with the noise. Today, our discussion will be mainly based on two case scenarios. These both patients came to family medicine clinic, home. So let's begin with our first patient. Patient name is Mr. A. He was a 51 years old gentleman with a came with a high-pitched musical voice, was requested to get a medical assessment by his working company. Actually, the working company, their main concern regarding this patient was the patient was having a shortness of breath on exertion, and also they have identified that patient is having noisy breathing. What patient complaint was he feel fatigue and lethargy at work and epigastric burning type pain for more than 5 years also he's experiencing. And he also told that he had regurgitation and dry cough, which make him wake in the night while sleeping. But he denies any history of apneic attacks or anemic symptoms. But he was insist that his voice was the same as since childhood. There was no any characteristic change with recent history. And there was no any events of angina associated with shortness of breath either, and neither wheezing. Patient was clinically euthyroid. Patient's past medical history was he remembers that he has been admitted in a hospital for a respiratory tract infection at the age of 8. Birth history was uncomplicated, and past surgical history, there was no any significant past surgical histories of any cardiothoracic, thyroid, neck or related surgeries, but he had undergone right inguinal hernia repair in 2008. Family is significant regarding thyroid disease or cardiovascular disease, asthma. History was a mental worker, currently working in a cleaning company, and living with he lives with his wife and son. And he was a non-alcoholic and not a smoker. There was no allergies. On examination, patient was well looking. He had a BMI of 20 kilograms per meter square. And we identified that patient is having a difficulty of opening the mouth, and he was afebrile. Patient was not pale or not tired. Peripheral no cyanosis noted, and no intercostal subcostal resistance noted, and no tracheal tuft. Trachea was palpated in the midline, and blood pressure was 120/79, and pulse rate was 76. There was no bilateral ankle edema or neither sacral edema. On auscultation of his lung field, the bilateral air entry was equal. No wheezing noted in lung field, but in the auscultation of the neck, we found that he's having a stridor in inspiration more than expiration. That was the only secret finding that we found on his examination. So, patient presented to us with his blood reports, which he has been ordered previously. It was fasting blood sugar to be 89 and total cholesterol, and they all were in normal ranges. And ECG, we found that patient is having partial right left bundle branch. Management plan for, so we thought mainly we should be considering regarding stridor problem and also this epigastric pain and shortness of breath. So we thought of investigating him on full blood count and ESR to see any infective causes for these symptoms. And we also thought of ordering chest X-ray to see any abnormalities. And we plan to do a 2D echo, and we asked him to take a date for that. And furthermore, as the patient was having stridor, we did the ENT referral at that time. Then after 3 weeks, 2 weeks, patient presented to us back after the ENT referral, and there they have attempted to do the indirect laryngoscope, but it has been failed as the patient was unable to open the mouth. And but they have attempted fiber optic laryngoscope, and they have noted that there were bilateral arytenoid swelling in the laryngeal region, and also laryngopharyngeal reflux was noted. We'll keep this memory, and we'll move into our second patient's history. Our second patient is Mrs. B. She was a 70-year-old female patient. She mainly complained of shortness of breath on exertion for 6-month duration. The main complaint was shortness of breath for 6-month duration and central burning type chest pain and regurgitation, which was worsened at night. She also complained that she was waking up at night with a dry cough. This patient was treated for central and epigastric chest pain at different medical services at different times, but not for longer duration, very short duration times. She has been getting treatments, but she had no improvement in her symptoms. Each episode of this chest pain was lasted to 10 to 15 minutes, which get worse at night and was associated with scapular region pain sometimes. Patient further complained that shortness of breath on exertion and recent history of passage of dark colored stools with an on and off events of constipation. But she denies any history of loss of appetite or loss of weight. In inquiring her past medical history, she has been investigated for this dry cough, so she has been investigated back for tuberculosis 4 months back, and the sputum AFP reports were found to be negative. But she neither has any history of hypertension, diabetes, dyslipidemia, or bronchial asthma. Past surgical history was not significant. Family history, she does not have any significant family history of ischemic or congenital heart diseases, bronchial asthma, or colorectal malignancies. About her drug history, she was several times treated for as bronchial asthma. Patient has been treated as bronchial asthma and has been treated with corticosteroids and antibiotics. But she was not on any history of prolonged use of NSAIDs or iron supplements or warfarin. Social history, she was an unmarried patient who currently lives alone, and she was previously worked at a cleaning service, and she was retired at that time, and she doesn't smoke or consume alcohol, but she tells that she was taking high intake of oily food and bakery products. And past gynecological history-wise, she was menopause at age of 40, but there was no allergies. We examined this patient. On general examination, patient was not pale, afebrile, and was not dyspneic, and no periorbital edema or ankle edema, and no central or peripheral cyanosis noted. Her BMI was 23.1. Her cardiovascular system examination, pulse rate was 80, blood pressure was 130/87, and dual rhythm set and no murmurs found. And respiratory rate was 24 breaths per minute, no tracheal tach or vesicular breathing, and bilateral lower zone mild fine crepitations were there. Abdomen, there was no distension, no scars, or no tenderness or organomically found on palpation. So significant things that we found in this examination was she had bilateral lower zone mild fine crepitation. That's all. Otherwise, seems normal. She came to us with these blood reports. There were hemoglobin was 13 gram per deciliter, and full blood count, there was a WBC of 12,000. It will be a neutrophilic count, and the fasting blood sugar was 92, and total cholesterol found to be 296, and LDL was 182. 12-lead ECG was sinus rhythm. We calculated WHO 10-year CVDs for this patient and found to be it was 19%. So before going to the next slide, can you here in this field our Mrs. B's history and examination?
The slides are not moving, Udan.
අනිත් පැත්තට මේ
We are experiencing some technical difficulties. Please bear with us.
I'm extremely sorry for the delay. I got disconnected. Sorry. So regarding Mrs. B's management, the differential diagnosis we thought of this patient was reflux esophagitis. And we thought of heart failure also because patient was complaining mainly regarding shortness of breath on exertion. And we also found that patient was having bilateral fine grips. And we also wanted to think about gastroesophageal carcinoma on this patient, as she complained that she was passing dark stools, and constipation was also there. As you remember, her full blood count was show some infective picture. We thought of lower respiratory infection also for this patient. In managing this patient, our working diagnosis was, our first diagnosis was reflux esophagitis. So we thought of managing on that line, but still we want to exclude our other differential diagnosis on her. So we thought of ordering ESR and also ordering imaging studies, chest X-ray, and date was taken for upper GI endoscope, and also date for 2D echo was taken. We advise her regarding the lifestyle modifications of for this gastro reflux esophagitis. We ask her to advocate healthy eating and avoid coffee, chocolate, and fatty foods, and also avoid large meals and consume small frequent meals. And also we ask the patient to have her meals for at night before 2 hours for the bed, and also requested to do raise head end of the bed and avoid wearing clothes that tighten the waist. And we educate patient regarding hydrotherapy. Mainly pharmacology wise, we gave her 20 milligrams of omeprazole twice daily for 1 month, and domperidone 10 mg TDS for 1 month, and also started on atorvastatin 20 mg noctate for the primary prevention of cardiovascular diseases. So we'll get into our first topic of discussion. It is the main gastroesophageal reflux disease. So as a definition, gastroesophageal reflux disease is a chronic medical condition caused by a flow of contents from the stomach upward into the esophagus, resulting in both symptoms and complications. But in order to diagnose this condition, these symptoms should be occurring regularly, at least 1 day per week. I went to a research article which was done by some doctors in Sri Lanka regarding gastroesophageal reflux disease in Sri Lanka. They have conducted this study along 25 districts across Sri Lanka and found to be that gastroesophageal reflux disease prevalence is 25.3. That means almost 1 out of 4 patients which encountered to us in a primary care, they may be having symptoms of gastroesophageal reflux disease. Also in this study, there was an interesting graph which shows the prevalence of gastroesophageal reflux disease according to the age and gender. There is interesting findings in this graph, which you can see that in the age group of 40 to 49, this index cases of male and female both, this gastroesophageal reflux disease is very high. And also you can see that the age range of 60 to 70, there's a comparative difference between this male and female. Actually, females are far higher in presenting with gastroesophageal reflux symptoms than male. The reason for this possibly may be the patients, females are getting obese with age as they move into the menopause, and they are increasing with their weight, and which lead to, as there's a direct correlation between gastroesophageal reflux disease and obesity that can be a cause, but it's a good point to discuss. And we'll move into the symptoms of gastroesophageal reflux disease. Out of all the patients who are diagnosed with GERD, half of them, 48%, may experiencing heartburn and consecutively chest pain, 32%, and bloating, 26.2%, and regurgitation, burping, cough, dysphagia, and halitosis, and odynophagia. So this is the most common symptoms, esophageal symptoms. Most common esophageal symptoms and some extra esophageal symptoms which these GERD patients are complaining of. And we can also see the complications of gastroesophageal reflux disease. This when discussing the complications of gastroesophageal reflux disease, it can be mainly categorized under two branches where first one is esophageal complications. Esophageal complications occur because the damage to the squamous esophageal epithelium. In that, increased inflammation of the squamous epithelium occur, which lead to the esophagitis. It eventually forms ulcers in the esophagus, and then collagen deposit occurs, and over the time, these collagen fibers contract and form esophageal stricture disease. In other words, when this damage to the squamous epithelium led to metaplasia of the epithelium, it lead into change into columnar epithelium and lead to Barrett's esophagus, which we have heard. And this, which eventually with time, it can go into dysplasia changes and go into esophageal adenocarcinoma. Those are the main esophageal complications that we see. And when speaking about extraesophageal complication, patient may be experiencing cough, laryngeal hoarseness, dysphonia, asthma, and postnasal drip, and ENT like sinus symptoms and ear pain. Those extraesophageal complications, the main reason is when damage, this acid reflux cause damage to the pharyngeal lining and the damage to the airway lining, which in turn cause cough sensory nerve endings are stimulated and vagal reflex is activated, and it activates the brain cough center. If this acid directly move into the airway, they can become irritated and it increase the with bronchial activity, which eventually lead to bronchoconstriction, which we see patient presented with asthma and chronic cough. In other way, that this fibroblastic proliferation and this deposit granulation tissue in airway lead to chronic laryngitis. As esophagitis, this inflammation lead to chronic laryngitis in the larynx, and this eventually goes into, as esophageal strictures, this goes into laryngeal and tracheal stenosis. So we talk about the complication that can happen in gastroesophageal reflux disease. So we'll move into some photographs of the above-mentioned complication. You can see a normal lower esophageal gastroesophageal junction in the first photograph, and second shows a reflux esophagitis case. And third, you can see the Barrett esophagus, where squamous epithelium has been displaced with column epithelium. There shows a salmon pink colored extension. And the final results is this adenocarcinoma at esophageal gastrojunction. And these are some extraesophageal complications. You can see a normal larynx, appearance of a larynx in the above picture. And in the below pictures, you can see that, which we'll be discussing, laryngopharyngeal reflux, which this acid cause damage to this laryngeal area, which cause posterior commissure hypertrophy. The final results, it went into tracheal stenosis finally, which shown there. So we'll be discussing about this LPR. What is LPR? It is laryngopharyngeal reflux. It is defined as retrograde flow of the stomach contents to the larynx and pharynx, whereby the material becomes contact with the upper air digestive tract. It is said that the patients who presented with change of voice dysphonia, there's 50% of them there's found to be having LPR. And also LPR has been implicated in the etiology of many laryngeal diseases, such as reflux laryngitis, subglottic stenosis, and laryngeal carcinoma, and granulomas, and contact ulcers and vocal nodules. Okay, as primary care physician, we have a big role here. This patient presented to us, so we can use a screening tool from the history. We can ask several symptoms of them and come into a clue whether the patient is suffering from LPR. The tool is a reflux symptom index. There are 9 symptoms of laryngopharyngeal reflux are discussed, and we ask the patient to grade those symptoms according to how they feel. And the maximum score is 45. And if a patient score more than 13, they are towards the diagnosis of laryngopharyngeal reflux. So this is the reflux symptom index. So for the calculation of these symptoms, the patient should be experiencing these symptoms for 1 month of duration, which first one is hoarseness and voice problems, throat clearing, excess mucus or postnasal drip, difficulty in swallowing solid fluids and tablets, and coughing after eating or lying down, breathing difficulties or choking episodes, annoying cough, sensation of lump or foreign body in throat, burning, heartburn, chest pain, indigestion or stomach acid, and coming up, which is called reflux. So I have calculated this RSI score for our both patient. Mr. A got 20 out of 45 and Mrs. B got 26 out of 45. So both patients in this patients have been towards the diagnosis of this laryngopharyngeal reflux. After we come into this clue, we can refer the patient for the relevant subspecialties, especially ENT, and there they can visualize this larynx by laryngoscopy, mainly fiber optic laryngoscope, and with the finding what they see, they can grade these findings with reflux findings score. They have mainly the findings are given marks, and the total maximum score is 26, And if a patient score more than 7, it is classified as having laryngopharyngeal reflux. In both these scores, one was subjective and other one was operative dependence. So in order to overcome this problem, the gold standard of diagnosis of laryngopharyngeal reflux remains multi-channel interluminal impedance 24-hour pH monitoring, which a probe is inserted into the esophagus and kept for 24 hours, and it is recurrently checking the pH. And percentage of time which pH remains less than 4 is graded according to severity. With that, we'll move into the management of Gastro Oesophageal reflux disease and LPR. So main crucial part of management of this GERD is lifestyle changes. Their weight loss having a significant part, and elevate the head end of the bed. Staying upright after meals, avoid foods which aggravate the reflux symptoms, mainly coffee, chocolate, carbonated drinks, spicy foods, acid foods, and oil foods. And avoid sleeping at right side down, and smoking cessation. It also has a significant improvement of symptoms. It is said that if a patient quit smoking for 1 year who's experienced GERD symptoms, he can improve symptoms by 44%, like half of symptoms can be improved. And also increasing the eating dinner time and the bedtime. Actually, it is recommended to have more than 3 hours. When coming into the management of this pharmacological management, this if the patient presented to us with heartburn and this GERD symptoms, but we have to exclude red flag symptoms. If the patient doesn't have any red flag signs, we can treat him with or her with 8 weeks of once before meal proton pump inhibitor. This PPI should be taken at least 30 to 60 minutes before meals, and we can continue it for 8 weeks. If the patient experiences complete release of GERD-like symptoms, then we can discontinue this proton pump inhibitor. But if by any chance, if this recurs, we can plan for esophageal gastro But if the patient does not have relief with this PPI, then we definitely have to schedule him for esophageal gastric duodenoscopy. But before that procedure, we have to tail off this proton pump inhibitors 2 to 4 weeks before the procedure. With this procedure, with the direct visualization, the grading of these findings can be categorized into Los Angeles classification. And accordingly, there are 4 main types of grades. If a patient is having Los Angeles grade classification BCD or Barrett of size more than 3 centimeters, then GERD is confirmed. But if the AGD was normal and also Los Angeles classification is in grade A, then we have to refer patient for reflux monitoring therapy with off PPI. Then if it is normal, then we can consider another cause for these symptoms, maybe psychogenic or any other cause, or cardiovascular, any other can be. We have to investigate on other causes. But if the reflux monitoring therapy is abnormal, then again the patient is coming into diagnosis of GERD. It was mainly discussed about the esophageal symptoms. Then patient presented to us as our index 2 patients. They presented to us with extraesophageal symptoms. So in that case, we have to take a detailed medical history to identify the potential causes, and we have to refer for the needed specialty. And if the patient is having typical GERD symptom with extraesophageal symptoms, we have to put the patient on proton pump inhibitor. It should be taken twice daily. It should be continued for 12 weeks. And if these extraesophageal symptoms get improved, we can treat as GERD. So we have to, as it is having extraesophageal symptoms, we have to continue. The maintenance therapy should be continued. But if there is no improvement, then we have to refer the patient for reflux monitoring therapy with off PPI. Or else, if these symptoms show extraesophageal symptoms only, we have to refer the patient for reflux monitoring therapy. So if the reflux monitoring therapy become abnormal, we can treat as GERD. If it is normal, we have to consider pH impedance monitoring. According to this, it shows that some patients experience typical GERD plus extraesophageal, and some can see extraesophageal symptoms only. There are cases because some patients with extraesophageal symptoms, there's a though it is not much common, patient can still present with extraesophageal symptoms only. We'll discuss about the pharmacological management of this GERD. Mainly the pharmacology agents which we can use for these patients are antacids, H2 receptor antagonist, and proton pump inhibitors, and prokinetics. And most important and most prescribed medication for this GERD is proton pump inhibitors, and treatment should be, as discussed, for 8 to 12 weeks. And it shows superior efficacy for heartburn and regurgitation to relieve, and it also improve the healing compared to the H2 receptor antagonist. If we discuss about the commonly seen PPIs, it shows that acid suppression potency is differ according to the each PPI. It shows that rabeprazole is the superior, and thereafter esomeprazole, thereafter omeprazole, thereafter lansoprazole, and pantoprazole. The highest efficacy shows by the lansoprazole, and lowest is by pantoprazole. Actually, esomeprazole shows superior acid suppression potency than omeprazole. This PPI should be taken 30 to 60 minutes before meals, once daily or PD. But it is said that dosing at the bedtime is not effective. If it is taken at night, it should be taken at least 30 to 60 minutes before dinner. If the patient complains of complication of gastroesophageal, if the patient experiencing gastroesophageal reflux disease complications, those patients we have to anyways put on twice daily dose. And we have to remember that those patients should be put on the maintenance therapy. No, then there's high chance for those complicated gastroesophageal reflux disease cases to be relapse. So we have to continue it after the main treatment. Then we'll discuss about the H2 receptor antagonist. There, the patient's persistent, it is better for the nocturnal symptoms. So we can add, if the patient is experiencing nocturnal symptoms more, we can add H2 receptor antagonist on top of the PPI, and we can ask the patient to take this H2 receptor antagonist before bed. When discussing about prokinetics in the management, it has limited evidence, but this metoclopramide has action which increase the lower esophageal sphincter pressure, which lead to augmenting the gastric emptying. So it can be, if the patient is already on PPIs, but still experiencing symptoms, we can put it as an add-on therapy. Because if the patient is experiencing that, we found that patient is having delayed gastric emptying problem, this is the drug of choice. So we can put patient on add-on therapy to PPI, but it should not be continuing for long duration, as it has side effects outweigh the benefits. Mainly the side effects are drowsiness, agitation, irritability, depression, and tardive dyskinesia. Some other agents not much commonly used are baclofen, which is a GABA agonist. It reduces the transient lower esophageal sphincter relaxation and reduce the reflux, and it improves the nocturnal reflux activity, and also belching episodes. And but It is also limited usage due to the side effects. Some other drug for sucralfate is also used in the management, but it is mainly advised in pregnancy. You can see the dosing of these above mentioned drugs from these two graphs. This management was mainly I got from the American Journal of Gastroenterology and NICE guidelines. When we coming back to the Mr. A, saw this patient, our first patient, had epigastric burning type A from more than 5 years with regurgitation, which increased the lying down, sometimes associated with dry cough at night. So that patient is having GERD and laryngomalacia. So gastroesophageal reflux occurs when the contents of the stomach goes into airway back into the esophagus, and this if it goes into the upper airway, it causes this LPR symptoms, which he had so swelling and narrowing of laryngeal tissues, and he had arytenoid swelling, you remember, and which time it can lead into laryngomalacia and causing this sickness. But do you think Mr. A really had a stridor? We heard something, but do you think Mr. A really had a stridor? We'll discuss about stridor as our next topic. Before discussing about the stridor, I would like to refresh your memories regarding this upper airway tract. Actually, upper airway tract begins with the nasal cavity and continues over the nasopharynx and oropharynx and larynx and extrathoracic part of the trachea. Those are the, and mainly the larynx is forming by 3 main areas. One is supraglottic region, other one is glottic region, other one is subglottic, those 3 areas. And the main functions of larynx are vocalization, deglutition, and respiration. So, the structures of this larynx, mainly we discussing about the epiglottis. You can see in the diagram, there's epiglottis and the epiglottic fold and the arytenoids. I will share a video. You can see these structures with this.
Produced by Doctor, your nose and throat consultants of Warren, Virginia. Endoscopy is ready to commence. Here we have a view of the intranasal cavity. The inferior turbinate is what humidifies the air we breathe. The endoscope is being passed through the nasal cavity. Aspect. Please note the soft palate.
Now we can see the pharynx.
Soft palate, up and down. Baby bottle.
Baby bottle.
The endoscope will now be passed inferiorly when we will get our first glimpse of the voice box.
Now we can see the larynx. This is epiglottis.
Note the posterior pharyngeal walls.
This is
together as the
pharyngeal wall and epiglottic folds are there, and arytenoids are there.
Here we have a good view of the voice box. The arytenoids are what move the vocal cord together as well as apart. The strobe light will now be turned on. The strobe light allows us to visualize the vocal cord vibration. Note that as the pitch
You can see
elevates,
vocal
the true
cords
vocal cords
vibrating.
become longer and thinner. When the vocal cords are apart, we are able to breathe in and out. A voice is created when the vocal cords come together and start to vibrate very quickly. The endoscope is now being reviewed carefully.
So we saw that the structures, mainly epiglottis and epiglottic folds and arytenoids. So if each of these structures accidentally fall into this airway, it can cause noisy breath or stridor. These all structures are very floppy. So we'll move into the musculature of this larynx. It is mainly divided into two parts. One is intrinsic muscles and extrinsic muscles. The main action of intrinsic muscles is to produce fine tuning of vocal cords and phonation. And these extrinsic muscles' main function is to elevate and lower the pharynx. Then we'll move into the nerve innervation of the larynx. Mainly, this larynx is innervated by superior laryngeal, external laryngeal, and recurrent laryngeal nerves. Except the intrinsic muscle, cricothyroid muscle, all the other intrinsic muscles are supplied by recurrent laryngeal nerve. And that's why recurrent laryngeal injury has a very huge place in causing dysphonias and voice problems. Moving to some definitions. Stridor is a harsh, high-pitched, monophonic, noisy breathing caused by turbulence due to the partial obstruction of the upper respiratory tract at the laryngeal or tracheal level. And the second definition is stretto. It is a low-pitched, noisy breath caused by turbulence due to the partial obstruction of the upper respiratory tract above the larynx, also called heavy snoring. This is actually which we commonly call as snoring. The cause is the origin of sound is above the larynx. This very common presentation thing, snoring. And wheezing is a polyphonic whistling sound occur following obstruction below the trachea. So any small bronchi by a foreign body or a consolidated form of infection, this happens during expiration. I have added some audio clips on this. I think it can't be heard. We'll need to lose. So how to categorize stridor? This stridor can be categorized in different ways. One is functional classification. Functional classification, we can see whether the stridor originated in inspiration or expiration. So any stridor experiencing only inspiration, it is high chance it is coming from supraglottic region. And any stridor from inspiratory and expiratory both we can heard, it is in biphasic. If the stridor is in biphasic, the origin of the stridor, there could be glottic, subglottic, and upper tracheal. All these three regions, there's high chance. Any stridor coming in the expiration, heard in the expiration, it should be originated from lower trachea. So in our index patient A, our first patient A had this inspiration more than expiration, expiratory stridor. So our patient's origin should be from some area of glottic, subglottic, and upper trachea. So we show that he had problem with this glottic region. So this causes for stridor, these causes can be categorized under two ways. One is congenital causes and other one is acquired causes. In congenital causes, it can be according to the anatomical structure, where supraglottic causes, it can be like laryngomalacia can be a cause, laryngeal webs can be cause, saccular cyst or cystic hygromas can be a cause, and glottic region, it can be a web, laryngeal web or vocal cord paralysis, and subglottic region, it can be a web, laryngeal web stenosis or hemangioma. In acquired causes, stridors can be acquired from trauma. It can be acquired from thermal and chemical and iatrogenic injuries, and inflammatory causes are also there, mainly which we call infective and inflammatory causes, acute laryngitis, acute laryngotracheal bronchitis, which you also cause croup, and diphtheria. Then foreign body, like laryngeal foreign bodies, tracheal, bronchial foreign bodies can cause stridor. Then allergies. This angioneurotic edema of the larynx or trachea cause stridor. And neoplasic causes are also there, where benign causes like laryngeal papillomatosis and malignant causes like laryngeal carcinoma. These all can cause stridor. These are some photographs from fiber optic laryngoscopy. First one show the normal anatomy, and second one you can see laryngomalacia case where there are tight aryepiglottic fold is tightened. Last shows mass on at the esophageal orifice. It is compressing the epiglottis. Then we'll evaluate the causes of stridor. Actually, this is more towards a pediatric age group. If a child presented with a stridor, the age of the child, we can think of some differentials. First one is if a newborn baby comes with a stridor, there is high chance it can be following a vocal cord paralysis or a laryngeal wave or a vascular leak. If child is on the age of 4 to 6, it can be a laryngomalacia case or tracheomalacia problem. And if the child is 1 to 4 years of age, can be acquired cause itself or else epiglottitis, who or foreign body. I hope this will be useful in acute patient management in pediatrics. And also we can categorize, evaluate the cause of stridor in the other aspect by associated features. Mainly the stridor is associated, if the patient comes with stridor, if it is acute onset, we have to think of foreign bodies, infections, anaphylaxis, and air burns. If it is a chronic, like our patients, chronic cause, we have to think of this laryngopharyngeal reflux, tracheal stenosis, subglottic stenosis, vocal cord palsies. And if stridor is more in the supine position than lying position, it is mainly can be following laryngomalacia or big tongue. If the stridor is with a strain of voice, the patient is experiencing change of voice, then think of laryngomalacia, subglottic or subglottic hemangioma causes, and stridor with apnea or hoarse voice. As we discussed, vocal cord level problems, it can be infective also. We can think of acute laryngeal tracheobronchitis and the previously mentioned chronic causes. And stridor worse with feeding, associated with feeding difficulty. The stridor is also worse with feeding. It can be the cause can be a tracheoesophageal fistula, or else experiencing compression by a vascular leak. This photograph was taken by American ENT surgeons journal. It shows that the patient presented with stridor. We have to see whether it is a severe one or not. We can, if it is a severe one, we can immediately resuscitate the patient. And if it is not a severe patient or it's a chronic cause one, we can do clinical findings on him. So mainly, if the patient's, this is a recap of what we have discussed. If the patient tells that stridor is inspiratory and snoring associated, then nasal problems like foreign bodies, neoplasms, polyps, and choanal atresia should be suspected. If patient stridor is with gurgling or muffled voice, laryngeal problems should be think of. And if the patient is afebrile, then macroglossia, neoplasm, adenotonsillar hypertrophy should be suspected. If the patient is febrile, acute tonsillitis and acute causes should be think of. Like infective cause should be think of epiglottitis, those things should be think of. And if the patient is coming with a stridor with a high pitch inspiratory voice changes and hoarseness, then we can think of laryngeal problems. This is the category that our both patient, Mr. A index patient 1 fallen in. And patient is afebrile, laryngeal mass, subglottic stenosis, and vocal cord palsy should be suspected. If febrile, epiglottitis or hook should be suspected. And if we heard this stridor in the inspiration and expiration both, so we have to think of tracheal problem. Actually, by basic stridor, we have to think of tracheal problems. It's acute one, foreign body, and chronic one, tracheal mass should be suspected. If it is only heard in during expiration, as we discussed, this bronchial problem should be suspected. Bronchial problem can be either symmetrical breath sound, so asthma is a possibility, and the asymmetrical breath sound is there. Probable most can be a foreign body. So we'll discuss shortly. We'll go through the management of stridor. So depends on the patient's clinical features. If we suspect an infective cause, we can have to order full blood count, ESR and CRP. Saturation is the utmost important thing. We have to monitor saturation. If there's abnormality, we have to go for the ABCD management. If the patient is stable, then we can do radiographs and see whether there are any foreign bodies. And if we have facility, we can go for MRI and see the airway obstructions. And chest radiograph is another thing which is important. Chest radiographs can be normal with the children with a bronchial foreign body. Therefore, if the history is suggestive of any sort of intake of any foreign body, or if the parents are worrying, we have to directly go for bronchoscopies. And here, the rigid endoscopy with spontaneous ventilation is the gold standard investigation. But if the direct laryngoscope is not suitable or failed, patient can be sent for FOL, fiber optic laryngoscope, to see any causative thing for this stridor. As we have spoken about chronic stridor and investigation and management, I would like to have a few words regarding in severe stridor management in adults. This if patient present with severe symptoms, we have to keep the patient sit upright, and if needed, check saturation. If needed, we have to give high flow oxygen, and we can nebulize the patient with adrenaline, and we can administer IV high doses of steroids, dexamethasone. If we suspected any infection, the patient presented with fever, we can give IV broad spectrum antibiotics. But we have to keep in mind that if you are suspecting at the age group of 1 to 4, like epiglottitis kind of picture in a child, don't go to examine throat. That is the most important thing. So here we comes to the end of our discussion. These are my references. If you have any questions, you can inquire.
Thank you, Dr. John, for very informative presentation despite some technical difficulties.
Udan Tissera here.
Yes.
Udan, you mentioned that as a prokinetic agent, we can give metoclopramide.
Yes.
Now, we usually give domperidone as prokinetic as well. Was there any evidence that metoclopramide was better than domperidone, or what's your take on that?
Yeah, actually, I go to this management from the American College of Gastroenterologists. They have actually recommended metoclopramide as the drug of choice. They haven't mentioned any domperidone in that research and journal.
Okay. Okay.
I think the metoclopramide is better than domperidone.
Okay. Okay. Thanks.
I think that's still domperidone is not a FDA approved drug. That may be the reason.
It's not FDA approved, is it?
Yeah, it's not FDA approved.
Okay. Thank you.
Won't you have any questions? Okay, I think I have seen some seniors here. I think I think Marsh is there, I suppose. Any
Yeah, madam.
comments? Any comments of this? You are this is the very first time. The first year registrar presented.
Yeah.
How can you give your comment about this presentation and about the facts he delivered? Anything you want to say?
Yeah, madam, because I would say it was a very well comprehensive presentation, and the facts and everything were, presented in a very methodical order. And I know the reason maybe why it was all in order as well. And madam, just one question from Udan. So first, while congratulating you, Udan, for the wonderful job, I would say I would say you all might be very much far ahead than us where we were, and thanks to your trainer as well. And I was just interested about what were the thought process on this patient's mind. I mean, like now this patient, now when we talk about patient A, he was going through with this problem for a long time, and had these job-related issues as well. So what were the ideas and concerns, expectations from this patient? And definitely been seen many specialists probably down the track.
Yes, regarding our first patient, his main concern was actually he was experiencing this shortness of breath on
Difficulty in breathing, isn't
Yes,
it? He was
yes.
rejected by their
The
employer.
working
Isn't it?
company. Actually, that was he was very worried that because actually he came to us for a medical assessment. Like his job was at risk.
I think several times he was nebulized, isn't it, Udan?
Yes,
Several times he was nebulized.
medicated.
Still the patients has a complaint of short of breath. And some people, they thought of heart failure. Can you remember all these
Yes,
things?
yes,
So frustrated at that time. It's a totally a switch to this thing to that, just treating with the PPIs and all this. It's after about few months he came. I mean, I think you were there, I suppose, Udan.
Yes, ma'am.
Yeah, he was so much relieved, isn't it?
Yes, he was relieved. Far better, like his symptoms were completely addressed.
Yep.
And
So
madam,
that's
there is something. Sorry to interrupt you, madam. Yeah,
no,
there is something.
Yeah, you
What
better
I
take on.
wanted to, madam, emphasize them, because now I would have be a bit happier if Udan would have added a slide regarding how he had catered the management plan for this patient, because definitely these patients are with so much of distress, and we see this, madam, day to day, and that's why why our discipline has to be there. I mean, like full-fledged. We have worked with you at Piliandala. We see how much they have been mismanaged sometimes and put up so many things in the head, and they are quite worried.
Mm.
And
Yes.
like most of the time, Udan, like just now, we have to like this is the main reason for encounter. So just what you have, I really like the way that you have presented the local facts. I mean, like with the what the Dr. Nilanka has published regarding the esophageal, the prevalence. Actually, madam, it's more or less like the Western world prevalence. It's
Yeah,
quite
very
high.
true.
Yes.
Yeah. And so that was quite new for me as well. I learned a lot. I mean, like it's where it's out there. We just mismanage most of the time. I mean, misunderstand for something else. And also, I really like the fact that how you had gone through the um, guidelines and the way you explained everything, and just always try to tailor made for try to have a slide for how you put everything, and how we ultimately what matters is how we have, because definitely you have done best for that patient, and just talking about the patient is quite important as well. Thank you,
Thank you.
madam.
Of course, that's actually a very good suggestion, Marsh. So I
Thank you.
think, I actually not at the beginning, you put a few slide, maybe a one slide, what the person's concerns, how he suffered, and how many years he suffered. He thought that he will lose the job just for like get something from us. Only he came with a very frustrated face. I think BMI is also very low, and he very frustrated. The same way, can you remember the second patient also in a little bit, I mean, the presentation is a little bit different, like same kind of, can you please more about this, about social, and can you remember that one? As I think you have all the things in your book, I suppose. Could you please tell me about that one as well?
Regarding the second patient, madam.
Yep, second.
Yeah, so hope you remember that she was living alone, madam.
Yeah.
And patient was like, as she was living alone, she haven't been cooked for a long time, and she has used food from outside every time, and this oily food intake is very high because of that. And she was so worried that she presented with shortness of breath on excision. Like we
And the
told,
same two patients, Marsh,
yes,
both presented in the same way.
same.
SOBE. So now the imagine the two different diagnoses. So all the when you come across a patient with SOB, most of the time the people, like that's what actually happened for those two patients. They think either heart failure, maybe the cardio or the respiratory is higher up in the list most of the
Yes.
time. So
True,
that's the
madam.
thing. So they do all these things, all the investigation, all the medication. But
Yes.
when it comes to, I'm not blaming anybody, but most of the time, so they give a trial of bronchodilators or
Yes.
else just a
Our
nebulizer.
second patient was treated like that, madam. Several
Yeah, the
times
both
for
patients were treated
bronchitis.
like that. It's very pathetic. So
Yes.
that's why actually I wanted him to do this job for, I mean, he did a very marvelous job, of course. I must say that. It's very, it's not like the very first presentation. As you
True,
all
madam.
like, as you told Marsh, like I see some sort of a, improvement in you all. So that's because, the very first time when you do those things, that's the beginning of this particular presentations. Like you hardly see few presenters what the family medicine registrars do. Right
True,
now,
madam.
every day they want to do more better than, it's not like a competition, but they want to do the best. Right, isn't it? So that's,
True,
I
madam.
see, some huge improvement. I'm I'm proud of you all kids. I'm very proud of you all. So that is how you should be. And
Thank you.
like so it's because our future is very safe, like when I see those things, isn't it, Marsh? Because since you are
True
a
enough, madam. Indeed. Because,
yes,
madam, I mean, like those days, madam, when we started off, we didn't have this online presentations and all.
yep,
So basically, we were thinking whatever we presented, whatever we
yes,
knew,
correct.
and
Halfway through only we started, isn't it?
true, madam. And I
Yeah.
always remember, madam, kind of like how you Because when I started off, like most of the time, even though I just ask ideas, concerns, and expectation, where we do not really look at it in a practical way, how to help the patient with that. But so that's what I wanted to tell Udan also, like the importance, not just merely asking what's the ideas, concerns, expectation, but then how we can incorporate in patient management is very essential.
It's good. So how about the second one, the year 3 registrars? Did you, because for y'all, it should be the academic things, because it's hardly, we see this kind of things. It's not, maybe we see, but we do not diagnose properly. It's very interesting. Anybody want to ask either questions or in some sort of a because we have to appreciate the very first year the registrar who presented in a nice, very, very well, good way. So could you please, anybody, I saw some people there. Hazar, of course, asked a question, but what about the other ones?
I was very amazed and so proud of Udan, madam, because as a first year registrar, the amount of research he has done, a simple case that presents to us on a daily basis is immense. I think, Udan, you taught us how to evaluate a problem extensively. So much. I mean, we wouldn't have thought to go in so much of depth for a patient like this. And thank you so much for the amount of information that you gave us, because for us it's a matter of studying like in a very short span, and I think with your presentation we have covered a lot of topics.
Exactly. It should be like maybe a week. You need a week to study everything. Right now, it's sort of
Yes.
in a nutshell, he gave everything. It's a huge section he covered.
Yes, Vanavan, thank you so much for that.
Thank you. Thank you, Dr. Sir.
Okay, then if you don't, anybody who wants to talk, or else we can wind it up. Like, Dan, want you to say something, or?
I'm happy about the comments, madam.
Yeah, that's the thing.
Thank you.
And just one thing, Udan, regarding the second patient. Now,
Yes.
since the patient presented at SOB,
Yes.
I remember, like you said in the examination, was there any fine crepitations?
Yes, there was.
Yeah,
Any
there
thoughts?
were fine crepes. So
There were
that's
fine
some
crepes.
sort of a thing we thought of, like heart failure.
With
But
the heart failure.
excluded everything.
Yes, madam.
Yeah, that's the thing. We excluded. It's not sort of maybe after, he was treated with all the I think even he was also nebulized. I cannot remember exactly. I think you must have all the notes.
Yes, madam.
And respiratory things as well at that time.
Yes.
Any possibility of ongoing any long-standing for possibly exposure to any kerosene or anything?
We all excluded
No,
it.
madam.
I think you better
Yes.
mention those things as well. We all included respiratory, everything. And then only we came to the diagnosis of that. Yeah. And
Yes,
like
madam, I could
sort
thank
of
you.
all by exclusion of the others as well. We excluded all the possibilities if a patient comes in. Yep. Better put all the everything, because you want to talk about the disease, but not only that, as Marsh told, we have to say how the patient presented and what are the ways we examine and excluded. Everything is all are important.
Thank you, Madam
Okay.
Elda.
Thank you.
Okay, right.
Good night, madam.
Good
night, everyone.
Good night, everyone.
Good night. Thank you.
And before you stop, how many the first years were there? Your batch, Udan's batch.
My whole batch was there, madam.
Whole batch was there. Good. So somebody should talk, not Priyanti, right? They were with them. Anybody from their batch? Because it's a very first time. he presented. Somebody should talk about that from the first years. Not to Priyanti, not Manoj. Because we are waiting for the same kind of presentation from the others as well. Nobody's talking. Why is that?
I think still left.
Now, madam.
All left?
Just now left, madam.
Oh,
Mhm.
but anyway, there are a few in your batch. I can see.
Shobana is.
Shobana is.
Yeah, Shobana, tell something.
Yes, madam. The lecture was very organized and it was very informative for us as first years, madam. Because though we are seeing patients like this, we are actually not thinking of a wide, in a wide way, like what he has presented. So it was very useful for us.
Okay, so that's
And
what
I
I'm
think,
asking
madam,
is.
Marcia, madam, and I think Udan have now set them a bar. Yeah, the minimum standards. Udan might have set them a minimum standards now. So they have to perform better than this, no, madam, in the subsequent presentations.
Yeah. Okay, then anyway, I'm very actually proud of you all. Not because just to dance presentation, I see the progress in you all. It's very good. That's what I'm expecting. So then you better decide who will the person who's, I think it's a Chaminda's thing next time. I'm not sure. It's up to you all to decide, right? Okay then. Okay, good night.
Good night, madam.
Good night, madam.
Good night, madam.
Good night, everyone.